And then we just have a few items to cover before we get started. And so just be aware that we're recording this session, so please don't include any confidential patient health information during the session. And there's a couple of icons for you to turn on your audio and turn it off. In other words, mute, and start and stop your video. And if you do wish to receive a CME or CEU certificate for today's session, we do send those out once a month, usually the second week following the session month. You do need to announce your name at some point, and some of you have already done that. So if you could, in just a few minutes, we'll open it up for roll call, and you can say your name and where you're from at that point. And if you don't have access to audio, you can always use the chat box. And again, here's the icons for starting your video and muting and unmuting. Our disclosure and accreditation statements are on screen. Those are required for us to send out CMEs for these sessions. And we do offer, we have an agreement with Molina and Blue Cross Blue Shield New Mexico. If you bring a case consultation to one of our telehealth sessions, you can be reimbursed by those two entities. And it's a significant amount. We don't have the exact amounts right at the moment, but up till last year, it was about $150 for the high end and then about $75 for the low end. So get in touch with me if you have any questions about that. We do that for AHI New Mexico, for Adolescent Health Initiative, every Wednesday at 8 o'clock. So if you're interested, just send me an email. And now's your opportunity to let us know you're out there. So just say your name and where you're from. And if you're in a group, of course, make sure everyone announces themselves.
James Fisk, UNM Peds.
Michael Klein from Presbyterian.
Okay, and there will be another opportunity, excuse me, to announce the end as well. So, and at any point during the session, you can let us know that you're out there using the chat box as well. So, all right, and again, I'm going to go ahead and hand it over to Alex, who is going to introduce it.
Okay, it's a list. For joining much. So I'll go ahead, and I decided to pick practice physicians as well as any nurse practitioner or other mid-level that works in these primary areas for kids see often, as they are the most common referrals that I would say I see in orthopedics. And so the topics that we will be going over, and I have no disclosures, are growing pains, torsional malalignment, either of the femur or tibia, genuvarum valgum, flat feet, toe walking, and idiopathic scoliosis. Some of the information I'm going to give you is not things that I expect you to do as primary providers. They're more kind of letting you know what I do as the next step in an effort to hopefully help many of you that are watching to kind of know when to refer. Okay. Let me know if you can't hear me well or anything like that. Okay, so growing pains. So classic history of growing pains are pain at night, pain in the middle of the night that wakes them up. They need Motrin, massage, or I've also heard first thing in the morning. So I've had some kids where they don't really have that classic pain at night, but they wake up with a limp, and families will videotape their kid limping in the morning, and then the limp goes away. The key is during the day, they have no problems. They run, play, jump. They never stop playing. It's always at the end of a busy day, the kid has pain at the end and requires massage and ice packs and Motrin and a number of other things. It can be localized. I've had kids where it's just one leg all the time. Usually it's not. Usually it's symmetric. The kid will point very vaguely at their leg. And like I said, it does not interrupt play. So easiest way to treat it is vitamin D. And I shouldn't say that it'll treat it completely, because it doesn't. Sometimes it doesn't seem to decrease their symptoms. Sometimes it doesn't work. But I know that's the first thing I do, is just tell them to supplement with some vitamin D3. They have the gummy bear form. You can get it at almost any store. And I usually shoot for that before drawing any blood. Kids don't like to get their blood drawn. Parents don't like to have to be there and watch their kid get their blood drawn. So I always just say, why don't we give it a try first? Give it a good 3 months. And I would say the majority of the time, families will tell me they noticed a decrease in the intensity of the pain and a decrease in the frequency of symptoms. So maybe instead of every night, it's 4 times a week or 3 times a week. It's enough that they kind of say, okay, I feel better about what it is, and I don't ever have to draw their blood. That's always the best way to go. If not, if they come back at 3 months and they're like, nothing's better, then I say, okay, my next step is to draw some blood. And I order a bunch of other stuff at the same time when I'm drawing blood, so that I'm not doing that blood draw, finding out vitamin D is normal, and then I have to do another blood draw. So I'm just ordering anything I need in the same sitting. So summary on just vitamin D. So healthy diet, exercise, and some sunlight is the best treatment. We still, of course, want them to wear sunscreen, which is why having the diet with some vitamin D is key. Any child with a fracture, just to think about the bone health. We run into a lot of kids where just it's not even on anyone's radar until they have 3 or 4 fractures. And then we're like, wait a minute, maybe we should think about it. So it's just something to think about for all the first line people that see them, is to just ask, does your kid drink milk? Does your kid get any vitamin D from any other source? If not, recommend a multivitamin or supplementation with a separate vitamin, because commonly multivitamins only have about 400 international units of vitamin D. So child, in terms of growing pains, like I said, it's the classic stuff at night. If you get a kid who's actually not playing during the day, they stop playing, those are flags and probably requires a little bit more workup. And the other reason why I say just try it is there's not a lot more you can do after vitamin D. If the vitamin D is not working, and let's say they have a low bone density or anything else, the next step for bone health is bisphosphonates. Those are not FDA approved for children, and they have a half-life of 10 years. So it takes a lot for me to go to that. So kind of their only option is vitamin D. So now let's go on to torsional malalignment. And feel free to ask, especially at the end of each section, if there's a specific question on that. Otherwise, if I don't hear any questions, I'll go on to the next thing, and then I'll ask for questions on anything at the end. So most common complaint I see in clinic for sure is this, in-towing or out-towing. Mostly it's in-towing. So here's examples. So these kids, so like the first one looks bow-legged. That's not bow-leggedness, that's torsional. Those are torsional problems, and I'll go more into each one. So here is just a spectrum diagnosis. This is a paper out of JPO, and it was from 2017. Just looking, kind of confirming what I just said, is we see a lot of this. So this was a retrospective review of a program over at Texas Scottish Rite, which is a very well-known pediatric orthopedic specialty clinic. And they have an in-towing clinic that's run by an advanced practice provider, which we also have at Carrie Tingley. Every Monday morning, we have an in-towing clinic. And that's where we try and get all kids with a diagnosis of in-towing under the age of 8. We get them all into that clinic, because this study showed that if you do that, which we lowered ours to 8, not 9, that the majority of them have just standard torsional alignment problems seen throughout childhood that are normal, and they grow out of it the majority of the time. Very rarely is there an actual problem. So on the next part of it, this was a 30-month retrospective review. It had 926 patients. 95% were confirmed as being a benign in-towing or similar benign diagnosis, such as internal tibial torsion, femoral aneurysm, flat feet, etc. 5% of the families requested reevaluation for the exact same concern, which I would agree. I see some like a year or two later and they go, well, it's not gone. But then I have to reassure them again, it's the same thing. Only 1.1% had a non-benign diagnosis, and only 0.2% had a non-benign diagnosis that was considered miss, meaning like diplegic CP and autism. Those were the only 2 cases that was found later because the family represented.
We do have a question that was chatted privately to me, which is how much vitamin D?
So it kind of depends on their size. So for younger kids, if they're real little, like let's say under the age of 5, I would recommend about 800 international units a day. Once they're maybe 5, and this is just based off the standard sizes of those kids. Once they're maybe about 5 years old up to probably around 10, they could take 1,000 international units of vitamin D a day. Once they're over 10, I can usually bump them up to either 1,500 or 2,000 international units a day. I'm scared to go 3,000 or 4,000 or to do those big doses of the 50,000 international units per day once a week, unless I have some documentation that they need it. Vitamin D is one of the few fat-soluble vitamins, and so you can technically overdose hard, but you can technically overdose. So I feel like those amounts that I listed are safe amounts. So back to the in-towing, here's another study on in-towing, just listing that it's primarily a primary care orthopedic condition. So many of these families probably do not have to be referred. And the reason is because of the typical benign nature of it. We understand that there's a lot of families out there that either see a pediatrician or a family medicine physician and insist on seeing a specialist. We understand that that happens, and we're always happy to see them. That's why we have the in-towing clinic. But it just so that you can kind of better tell the families kind of what's going on. I would say the most common part of the natural history that's left out of in-towing when the families come to me is that they say, my doctor told me it would go away and it's not gone. And I go, well, no time frame was given. So it's not that it'll go away in a few months. It's going to go away in years, probably around 7 or 8 or 9 years of age. And it doesn't go away 100% of the time. It goes away 80% of the time. And so if some of those stats were given to families, maybe they wouldn't be as kind of bugging you guys as much too. So this is just showing again that very rarely is anything wrong that needs something. It's typically benign. So here are the reasons for in-towing. The first one is femoral anaversion. That's a twist in the thigh bone. This is an example just showing 2 cadaveric thigh bones. One has a lot of anaversion. That's the one on the right. The other one does not, has kind of a normal range of femoral anaversion, which is around 13 degrees. Everyone is born with a lot of femoral anaversion, about 40 degrees of anaversion, and it slowly decreases over time, which is why children commonly W-sit. And they in-tow when they're young is they're born with a lot of femoral anaversion. It slowly goes away with growth. There are no special shoes or braces that untwist the legs. And I'll show you some examples of braces that we've tried in the past that don't work. So here's the W sitting. So the W sitting did not cause the femoral anaversion. They W sit because they can, because it's already there. It is no functional hazard. I have told families to not let their kid W sit to encourage the crisscross applesauce, almost more as a way to give them something to do. Kind of stops them from coming. It is definitely more obvious when tired. So families will say that it gets worse at the end of the day. And it's because the kid's not working as hard. They're tired. They're not working as hard aiming their feet out. It's a lot of work. If any of us try and walk, push your feet out into like a duck position and walk like that for a while, it's tiring. That's what you're basically asking these kids to do. So the other thing I have to tell families is don't nag them. Don't tell them, walk straight, walk straight. It's very tiring and it is a little bit painful in the hips. So here's how I kind of look for it. So that's just an illustration on the top left of the cadaveric bones I already showed. Notice this child, the one where it shows them just pointing their legs out and you could twist them in so the kneecaps are aimed at each other. When you lay them on their tummy, that's my favorite way to check it, and you just let their legs flop down. You could see that the bottom left photo shows the legs flopped completely down. That's significant amount of anaversion. That looks like it's completely okay for a child of that age. That kid looks about 5. Not okay if they're 13, because that's not going to go away. So here's an example of a teenager who still has a fairly significant amount of femoral aneurysm. This is not okay. So this is a part of the 20% of kids that it did not completely correct with growth. So these are the kids that do sometimes have hip or knee pain problems, and we sometimes do surgery on them, depending upon if they are symptomatic. We never do it just because they can do that. Tibial torsion is the other reason. So this is just a twist in the shin bone. So it's just the next bone down can be twisted in. This should be untwisted at a younger age. So what I tell families is the tibia should untwist by 8, the femur should untwist by 10. And I say 80% of the time that will occur. Out of the 20% that it doesn't, I go, come back and see me when they're 10. Because at that point, their legs are their legs. So we are going to have to discuss whether we buy it or not. So here's a good way to look for internal tibial torsion. You could see the age is completely appropriate for this. The foot's just aimed in when you look at the thigh-foot angle. There's an example of that. And this is why they have it. This is simulating what they look like in the uterus. You could see that the legs are folded on each other. And this is also why it's commonly asymmetric. One leg has to be the outside leg. So that leg is folded more than the other. And that's why internal tibial torsion is commonly worse on one side than the other. This is another way to do it because you could do it at the same time. You could flop the legs down to look for femoral aneurysm, then hold the foot up and you see the same thigh-foot angle. Here's an example in a real child photograph. That's a lot of internal tibial torsion. Notice the foot is pushed down so it's at neutral. So natural history, like I already said, 80% of the time it will correct by the age of 8 or 10. Out of the 20% that do not fully correct, I rarely have to do surgery. A lot of them I go, well, that's why we have some natural pigeon-toed people, some natural duck people. It's okay. It's just not okay if it interferes with gym class, interferes with their sports, and causes pain. That's when we start saying, okay, well, maybe we have to do something else. And it's usually pain either in the hip and knee for femoral aneurysm, knee and ankle for tibial torsion. So here are some of the braces that have been tried. We generally stopped bracing completely for in-toeing in the early 90s because we had a number of very large studies, most of those were out of Canada, showing that none of this works. So you'll get families who say, well, my brother or my cousin or my niece, someone was braced and they're better. The honest truth is they would have been better anyway. I still get physical therapists who will use these. I do bracing in kids with cerebral palsy, but that is different. Their in-toeing can get worse over time, and their in-toeing can actually respond to these. Not true of a child that does not have a neuromuscular disorder. So metatarsus adductus is the only little bit of an outlier. If I catch this early, meaning under 3 years of age, I can commonly brace or cast it. Over that, bracing and casting will not work. I rarely do surgery. Like basically I've done it once in 7 years because she couldn't fit into her shoes and it was more of a fixed adduction. Usually, even when they're older, the foot looks a little bit like a bean, but it's flexible. They don't have any problems with shoe wear. They just don't like the way their foot looks when they wear flip-flops. But that's not an indication for surgery at all. So if they're young though, I can actually correct this. So that's why this is the one thing that if you see a bean-shaped foot in a baby, I would like you to send them fairly early because sometimes I need to cast, sometimes I could go straight to the nighttime shoes. So any questions there? Can you pop up? Nope. Okay. So let's go on to genu, varum, and valgum. That's bow-legged and knock-kneed. So there's some physiologic changes that occur with growth. So kids are supposed to be bow-legged up to about 3 years of age. Between 3 and 8-ish, they're supposed to be knock-kneed. And then after that, they bounce straight. So I see a whole bunch of kids that are basically in their normal range. And so the mechanical axis is typically what I use to gauge if they're bow-legged or knock-kneed. The first thing I do is rule out a torsional problem. Once I know that they don't have any torsional problems, then I can get a joint survey of the legs and I can measure their mechanical axis. So this is just a graph showing the same thing. So from the time they're born, they go bow-legged, which is, see how it bounces down, and then they slowly correct at around kind of that 7, 8, 9 areas when they finally bounce to normal. So here's an example. First picture, bow-legged. Next picture, knock-kneed. Final picture is normal, which everyone is 6 degrees knock-kneed. That's normal. So this is what I mean by the mechanical axis. Not every place has the ability to do a joint survey. So if you're concerned, send them. But the other thing I'll say is they should be around 10, because I can't really surgically fix this until 10 unless it's severe. So if it's Blount's disease, if it's something else where it's extremely severe, one side, send them early. But otherwise, if they're just kind of in this normal range, like, yeah, they're just not bouncing out of it. They're still kind of knock-kneed, and now they're 10. That's when you send them. So if you draw a dot right in the center of the femoral head and draw a line straight down to the center of the ankle, that line should fall in the center of the knee. If they are bow-legged or knock-kneed, that line will not be in the center of the knee. It will be on one of the sides. And so that's how you draw the mechanical axis. And that's what's nice is you don't need numbers, you don't need anything, just draw the line. And if it's not in the center, you can send them. So, like I said, 10 years old is kind of the key. I don't want to see them at 14 or 16 because by then they're almost done growing and I can't fix this anymore. We use something called guided growth to fix it. And it only works if they're growing. Bracing and special shoes will not change correction. That's the other thing. So basically I tell families the same thing almost like multiple times a day with in-toeing, out-toeing, knock-kneed, bow-legged. If there is anything you don't like about your child's legs at 10, come back and see me. And I also give them a website to go to. Orthokids.org is a nice one because it has good information explained in an easy way. Is there any questions on that section? Okay, so let's move on to toe walking. So I see a lot of this as well. Toe walking is a normal stage of development under the age of 5. Over the age of 5 is when I feel like it needs to be broken. There is a very high association of ADHD or other similar diagnoses with it, which obviously I don't treat those, but I usually ask families if any of those exist and I make them aware of the association. Under the age of 5, I don't worry too much unless the child is very high up on the toes and never drops down. Those are the kids where maybe I do something younger. So the flags that all of you should look for is toe walking on one foot. Those are the problems I've had. That's not normal. Immediately think either cerebral palsy, limb length difference, or hip dysplasia. Those are the kids that have a dislocated hip and they're 2 years old and they come to my clinic after they've already been going to physical therapy for toe walking on one side. So those are the stuff that you just have to think about. Toe walking on both sides is when you think either diplegic cerebral palsy, or there is a family, like a familial spastic paraparesis diagnosis, but typically there's a family history of toe walking in those cases.
And we do have a question from Jillian Mayer. Any difference with preemies?
With preemies in terms of the bow-legged and knock-kneed or the toe walking?
Sure.
Not sure.
I think it was toe walking because that's when
it popped up?
Came in.
Okay, so in terms of preemies, I mean, you kind of age adjust it, but it shouldn't be more than a month or two in terms of the toe walking. So, I mean, it's not like on their 5th birthday, I would have a really hard cutoff. That's just kind of like my age range where I'm like, okay, under the age of 5, it's kind of a normal stage. And I feel like that's how they build arches. Because when I tell families with kids with flat feet, I'm like, have them walk on their toes, have them try and heel walk. That's how you build an arch. That's how you strengthen the posterior tib tendon. But once they kind of go past 5, that's kind of now when I start thinking, okay, this is not okay. They really need to drop down. They need to learn how to heel to toe walk. So it's kind of just a general guideline. And preemies, obviously, I would think higher on some of my other things. I think, am I missing a cerebral palsy? Things that are higher in preemies. So treatments for toe walking, I usually start with just talking to the family and saying, number 1, if they keep the kid flexible, meaning I could get the foot up to neutral or past neutral with the leg straight, then we have all the time in the world to break the habit. If the foot is getting stuck in equinus, then I have to do surgery and then we work on breaking the habit. So that's where I tell families, as long as you keep them flexible, we could try all kinds of stuff. And it can take us a year or two to break the habit, and that's okay. So step one is stretching, keep the kid flexible. After that, we can talk about physical therapy to work on heel to toe walking. Real little kids don't really work with physical therapists. They don't listen to anything they say, which you would expect. And so it's just a lot of playtime. So those are the families where I just kind of say, just work on stretching and see what you could do. Once they hit about 5 and up, they really will kind of participate with the physical therapist. So that's where I have a lot of families where once I go through all the treatments, they typically choose physical therapy first. After that, casting can sometimes work. I usually cast both legs. I've had some families who don't want both casted because it is a lot of work to take care of those. So they just want one leg casted. And we just put casts on them for a month. They're walking casts, but they hold the foot flat. So the kid cannot toe walk if they want to. They'll try, and the only way they can go up is to bend their knees. So I'll get families who tell me, oh, well, they're still toe walking in their cast. I'm like, impossible. But they're bending their knees because they're so used to that they kind of walk with their knees bent. But casting works pretty well. A lot of kids, though, once you take the cast off, because it's a habit they've had for a long time, will do really well for about a month, and then they slowly start going back up on those toes. And so that's why typically when casting is done, they have to go to therapy. Some kids have failed the casting a few times, or the families just don't want to do the casting. And so those are the ones that I brace. So an AFO lasts for about a year. And so I tell them I want them to wear the AFO during the day, all day long, off around dinner time, like maybe 4 or 5 o'clock, take the braces off. And then that way I know when the habit's broken. If they wear the braces all the time, then I'll never know when the habit's broken. So I go in the evening is when you watch them and see if they're not doing it anymore. Surgery, like I said, is only for release of the equinus contracture, so it's a gastroc recession. A lot of families come to me thinking that I'll do a surgery that stops them from toe walking, and that doesn't happen. So any further questions on toe walking? Negative. Okay, great. Let's go on to flat feet. So natural history of flat feet. So 20% of everyone in the population has flexible flat feet. What that means is they look flat when they stand, but when they go up on their toes to reach for something, they have a really nice arch. Little kids commonly will have this appearance of their feet. And I think that's why naturally kids hate shoes. They get home, they want to take their shoes off because they want to play, they want to do stuff. And I think they're trying to build arches. I think it's a natural thing. And so I tell a lot of families, take the shoes off when you get home so that they have to climb, jump, run, do everything without shoes so that they can build arches. But then I also tell them it's okay if they don't build an arch, because 20% of everyone out there has flexible flat foot, and that's okay. It's like having different colored hair, blonde, brown, whatever, it's okay. Oftentimes runs in families, so you could almost always say mom or dad. You know, they're like, oh, my feet look the same. Okay. Normal appearance at a young age, flexible flat feet. So treatment. So number one, if they come and see me, they have flexible flat feet and it does not hurt. Nothing. I reassure the family. I explain to them the 20% thing about a whole bunch of people have it and it's okay. If they're under the age of 5, I tell them, oh, work on toe walking, hill walking, do all this stuff to create an arch. If they're over 5, you kind of miss the boat. You can't really create arches anymore. And so that's where I just reassure them and say, it's okay. Don't worry about it. Your kid is fine. And just promote strong feet. If they're painful, that's a different story. So if the feet hurt and they're flat, then the next step we try is that little brace. It's called a supramalleolar orthosis with a UCBL modification. That's to grab the hind foot and turn it in. The biggest thing is it will not create an arch. You take the brace off, their feet are flat. That's just how it is. But it can help with pain. If painful and they failed the conservative management, or I have kids who do great with the SMOs. They're like, I love the braces. They make my feet feel good, but is there something I could do where my feet feel good like this all the time, but I don't have to wear a brace because they don't want to wear the brace? Then that's where you do a surgery. The surgery does the same thing as the brace, but inside. Works a lot better if the kid is older. So early on, we usually brace. And I've had a few kids that are like, I don't mind the brace, and they just wear the brace all the time. Another common thing that happens is in their teens, they'll say, well, I wore a brace for 3-4 years from the time I was 10 to 14. And then I grew out of the brace. I forgot to get a new brace. And they go, but my feet don't hurt anymore. And I go, then great, you don't need another brace. Again, if the feet don't hurt, we'll leave them alone. Any questions on flat feet? Because it's another common one that I get.
What if the feet don't hurt, but the knees are starting to bother them?
Yeah, so that's where it is extremely common that you have an association of knock-kneed and flat feet. So sometimes I've had people who've had tons of surgeries on their feet, like by podiatry, and the whole time they were knock-kneed. You correct the knees, the feet feel better. So that's where, or vice versa, you know, but almost always, like if you even try and buckle your own knees in, watch what happens to your feet. They drop in. So that's where immediately I'll look at the knees and I'll go, we might need to get a joint survey. And if they're the appropriate age, I could straighten the knees. And I've had a whole bunch of them who their feet feel better and we don't have to do anything with their feet. And then I have this small group of kids that I straighten the knees and I still have to do the feet. But usually you don't. Because I do think the knock-knee throws the weight bearing off more than the feet.
Right.
And if you fix the knees, it's a lot better. Okay, so the last thing is scoliosis. So just the definition, it's derived from the Greek word crooked. Coronal plane deformity. So the picture that you see, that is the coronal x-ray. And that has to be at least 10 degrees to be called a scoliosis. Under 10 degrees, we refer to it as spinal asymmetry. The reason is if your back hurts and you get an x-ray, you can have that type of a curve. You can have an 8-9 degree curve. You go to therapy, back feels better, curve goes away. And we've seen that tons of times. So the curve has to be over 10 degrees to even be called a scoliosis. From there, you look for a rotation, you look for other stuff. So then you also have to make sure that it's actually idiopathic scoliosis. So you have to rule out the congenital, the degenerative, the neuromuscular. And then if you rule all that out, then you know it's idiopathic, even though it's extremely common. Still just ask the questions, do the physical exam. So
you have a question.
Yes.
With flat feet, can weight loss in the obese patient improve the pain, and improve the condition, or just the pain?
So it can improve the pain. It will not fix the feet. You know, if they're flat, they're still flat, but it can definitely improve pain. We know how weight is multiplied per joint, hip, knee, and foot. So I used to tell adults when I was a resident, if they lost 5 pounds, that will feel like they lost 30 pounds to their knee, because it definitely amplifies. So it helps. So weight loss is always is something good to approach. With kids, it's sometimes harder because kids eat what's in the home. So you have to talk a lot more about the whole family education and how the whole family needs to eat healthier. Otherwise, the kids are going to eat what the parents are buying, which is sometimes harder for us. So here's a table from a paper that was JBJS, just basically showing risk of progression. So just to kind of go through what the table is basically saying. So the Risser sign is the scale of 0 to 5. It's the iliac crest growth plate. So when there's no growth plate there yet, meaning like no bone has appeared above the iliac crest, that's a 0. And then once they usually, like when girls start their period, almost always that's when they get to a 1. It's about the same time. And then skeletal maturity, meaning no more growth, is a 5. So if they come as a 0 or a 1, basically just meaning young. That's what that means. They're young. And they have a curve that is right around 22 degree average, okay? Their risk of it progressing is like 68%. I mean, those are the highest group kids. If they're a little bit more mature, 2, 3, 4, then their risk of progression is much lower. So that's why I'm just pushing finding it early. We have not had problems with kids getting missed. I feel like a lot of family medicine doctors here in town, as well as the pediatricians, are very good at checking the bend forward test all the time, just the Adams forward bend. always checking it, and we get lots of kids sent. So I haven't had problems where kids have been missed frequently. So I feel like in general, people are doing a great job. But this is one where I'm like, anything off on the spine, I'm happy, send it. Because if their back hurts and they have a little curve from back pain, you will not see the rotational change. So when they forward bend, you shouldn't see that change. Rotational changes occur with scoliosis. So that's just kind of a push to keep checking every year, send them if you see anything off, or you can get an x-ray and then send them, I don't care. But we have in clinic a protocol where if someone's being sent for scoliosis, we ask them if they have x-rays. If they don't have recent x-rays, we get them at that visit. So if we've had a whole bunch of kids sent just because the scoliometer's off and no x-rays, we're fine with that, 100%. We just want to catch them early. So it's just showing the drastic difference between those. Risk of progression from 1% if they're a little bit older to 68% if they're younger. So here's just an example of that research staging. So natural history. So this is after skeletal maturity, because everyone kind of says, well, what's going to happen long term? So these are the talks that I have with families. So our goal is to keep a curve under 40 degrees. Under 40 degrees, they tend to not progress. That will be their spine for the rest of their life, and it's absolutely fine. Over 50 degrees, now it will progress slowly, which is why it's never an emergency. All these families, I never tell them, oh, we have to do surgery next week. It's over 50. When do you think we should do this? This summer? This coming winter? Like, we're trying to prevent the 80-degree curve. So we can finally plan it, and it's okay. The curves between 40 and 50 are the ones that I tell families are just kind of up in the air. We have to see. We have to see if it's going to slowly progress like an over 50 curve, or it's going to stay the same like an under 40 curve. And I do have a couple kids that are right at like 43 degrees, 44 degrees, and they're always there. So they just don't progress, and there's nothing to do if they don't progress. Lumbar curves are harder. They tend to tilt the pelvis more. They make kids look like they have a limb length difference. Those are harder to deal with, and we tend to do surgery on those a little bit earlier. So natural history. No increase in mortality. The respiratory failure can occur over 110 degrees, but you do start seeing changes in their PFTs at around 70 degrees. Chronic back pain is extremely common, but it doesn't seem to interfere with their ability to work, but they do have chronic back pain. One of my partners does pediatric as well as adult spine. So he's a good one that if they're older, I tend to put those patients with him because I know that they need a good 5-year follow-up, and he could follow them even into adulthood. So here's an example of the screening, the Adams forward bend. Now, here's the controversy. This is different organizations say you should screen, and then there's other organizations that say you shouldn't. So just to, I'm sure a lot of you already know that that's controversial. But we, because I'm a part of AOS and SRS and POSNA, I feel like screening is important, but you could see that the British Orthopedic Association as well as the United States Preventive Services say it not to screen. To me, I'm like, it's easy to do a forward bend. Just have them bend forward and look at their back. That's easy. I don't see why that anyone would be against it, but some organizations are. I think you should screen. So in summary, I feel like screening is fairly reliable. You could see the asymmetry of this girl's back. And when I do the Adams forward bend, I kind of slowly look at the whole back. And when I have them come up, I have them come back slow when they stand up. And that helps me as they come up. I kind of look from the lumbar spine to thoracic to cervical as they roll themselves back up so I can make sure I'm looking at everything. The other thing is I left some of those studies out, but bracing works. That is the one therapy that we know can alter the natural history. Not 100%, but about 70% of the time, you can prevent a child from needing surgery. So bracing works. We ask them to wear the braces 18 hours a day. And I do have some pictures of braces. So Cobb angle is what we use. There's a plus minus 5 degree measurement error, and I have to tell families that so they don't freak out with a 1 degree change. Risser sign, so in every one of our notes is location of curve, degree of curve, Risser stage. Oh yeah, we're just circling. I always shoot PA x-rays. It decreases radiation to the breast tissue. Very important. Side view shows the rotation. You can see the ribs are off. So anything atypical, get an MRI. So the curves in adolescent idiopathic scoliosis should go to the right. You see a left going curve, you see reflexes are off, weakness, cavus deformities in the feet, anything else. I tell the family I got to rule it out. I have to get an MRI. They're never upset about it. And I have caught some syrinx in the spinal cord. And I've also caught a couple of Chiari malformations. And there's just a chart showing what I told you earlier about progression. So here's some of the braces. We use the Boston TLSO most often. So our brace, notice that one goes underneath the breasts. The Boston looks the same in the back, but goes over the breasts. But notice they have like little pads in the front. There's lots of braces out there, but at Carrie Tingley, we typically use the Boston. Same with if you write a brace for anyone and they take it to Hanger, which there's like 3 locations in Albuquerque. And we have a lot of Hanger locations around the state, which Carrie Tingley is only in Albuquerque. So a lot of families go to Hanger for that reason. They also do the Bostons. And they have heat sensors in them, so we know how much they're wearing them and how much they're not. So just knowing they're there works really good. Just knowing that we're going to get that data. But 18 hours a day, that's what we ask. So it's best for young girls is who it works good for. Lower BMI, as you would expect, it's easier to push on their spine if they're thinner. If they're heavier, it's hard for the brace to kind of reach the bones inside. And summary on this, bracing works. We want to see them young, and the curve will never go to 0. A lot of families think that if we brace them or do surgery that we can make their spine completely straight, and we can't. We typically can improve it by about 50%. So families just need to know that. Our goal is not a straight spine. Our goal is hopefully to prevent surgery and balance. We want shoulders balanced and pelvis balanced. Want the head over the pelvis, front view, side view. That's the goal, either with the brace or with surgery. That's the goal. And let's see, indications. Yep, we already went through that. And then in terms of surgery, like I said, it's improved not only cosmesis and body image, but it's the balance that we're looking at. So here's some examples of spines treated surgically. You can see that the curve is not gone on this young lady, significantly improved. You could see how much her right shoulder blade was sticking out before, and now her shoulder blades appear more symmetric. Shoulders are level, pelvis is level. That's really the goal. But it's obviously a big surgery. You can see the size of that scar, and you can see how much instrumentation is inside. So there are no long-term prospective controlled studies yet. So we're still waiting on those. Obviously, it takes a while to get those. It's not a small surgery, 4 to 7 day hospital stay, 6 months of no sports, contact sports specifically. And then there's some risks. There's risk of infection, pseudarthrosis, which is not fusing a portion of it. Reoperation, neurologic injury is always a risk. We try, our goal is not to expose the cord at all, but the screws are going right next to it. And it is expensive. So, in summary, we've gone through this. It is a 3-dimensional deformity. It's not just curved on the PA view, it's also twisted. And please do screening. And that's it, references. Well, this is references for everything. And then just centralized scheduling, we have an appointment number. We have fracture clinic about 3 or 4 times a week. We have an in-towing clinic. We have a whole bunch of clinics. So it should be easy to get to us. It's the same phone number for all the clinics. And I'll open it up to any other questions on any of the topics I covered.
We do hear somebody talking, but we can't really hear you. It's probably important.
See that one question? For the last slide, when to begin?
Right, okay,
Oh.
sorry. So for the last slide, when to begin scoliosis screening?
As soon as they can actually bend forward and touch their toes. Because there is a large number of kids with early onset scoliosis that we can treat with body casting. And I do the majority of the body casting for early onset scoliosis. But as soon as those kids are able to be tricked to bend forward to touch their toes, look for that. The other thing, though, about early onset scoliosis is those curves always go to the left. So it's the reverse of adolescent. Their curves go to the left, adolescents go to the right.
And it's okay if they go to the left.
If they're early, that's still idiopathic. Yeah, that's what's weird, is those are the kids that are fine, but their curves go the other way. So just so you know, don't freak out, start ordering MRIs on everyone. Just send them, because then we can evaluate them. And if they get body casted, we MRI them beforehand. But if it's a low curve, I'm able to brace them without having to put them through a general anesthetic and getting an MRI, because that's obviously an undertaking. So, and we don't want to be causing ADHD reading problems. We don't want to be causing all that, because all the anesthesia literature shows 1 surgery under the age of 3 safe, 2 surgeries, and that just the anesthetic under the age of 3 has been linked to reading problems and ADHD. So I try not to MRI if I don't have to.
And what is the likely cause of growing pains, especially if vitamin D levels are normal?
Yeah, we don't know is the hard thing. I do see in families that some families just struggle a lot with growing pains, and either the mom or the dad also struggled when they were young, but it's not correlated with the tall kids. It's not correlated in any way with that. So we have some kids that just struggle so much with growing pains, and then other kids don't, and we don't really know why. I know that vitamin D typically helps. What I've noticed is the kids that it doesn't help, and we proceed with the big time workup, and we get the blood, we end up sending them to rheumatology, we end up doing all kinds of stuff, and by the time that massive workup is done, their growing pains are better. So I don't know.
Okay, another question. I have had some patients who are in sports like volleyball and swimming. I don't see spinal curvature, but their one side of their back appears higher. X-rays show no curvature. Is this something to be concerned about?
Yeah, so I do think that there's some kids out there who, and I have about 4 kids that I follow that are just like this, where when they bend forward, I'm like, that is obviously off. But when we get the x-rays and when they stand up straight, they look straight. And so I think there is this subset of kids that have primarily a rotational deformity, but not a scoliosis that you could measure with a Cobb angle. And I know it's them because every time I see them, the resident presents them and I look at their x-ray and the x-ray is pretty straight. I'm like, why do I keep seeing this kid every year? And then I go into the room, do the exam, and I'm like, oh yeah, that's why. On forward bend, they have a massive rotational curve, but not a curve that you could measure, a curve you could measure with a Cobb. So I just follow those kids annually because I don't want to over radiate. And I follow them till they're 18, but I'll tell you, I have not had one progress. It just scares me to let them go until I know they're done growing. But I bet you that's what it is they do have a rotational deformity, but it just never seems to get worse. That might be it.
Any other questions? And I do want to remind you as well as we're wrapping it up here, if you haven't already let us know that you're out there, what your name is and where you're from, please do that in order to receive your CME CEU certificate. We also have a post-session survey that we would really appreciate you taking. It just takes a couple minutes. It's just a few questions. Just helps us improve our sessions both technically and topically. So please take a few minutes to do that for us. I'm going to chat that out right now. And thank you, Stephanie. It's like we're getting chats of roll call at this point.
Which is great.
Hi, Dr. Mason.
I recognize a lot of his names.
Dr. Mason was able to be on the session today.
Good. All right. Well, thanks everyone for listening in.
Thanks for joining us.